Okay. So this is a very instructive case for trainees. So I would say that if you're a trainee in radiology, I suggest you pause the video if you're watching the video to look at this PA in lateral for some time and try to identify the findings. This is a radiograph, PA in lateral from 2002 that was interpreted as normal, which it clearly isn't. So this is an important diagnosis for a radiologist to make, because in my experience, inexperienced trainees and certainly non-radiologists typically do not make the right diagnosis or the right observations. So here they are, frontal and lateral. There is abnormal opacity, and the corresponding opacity on the lateral projection is posterior. The expected interface between the left hemidiaphragm and lung is effaced here, and it is also effaced posteriorly. There is an abnormal interface, or an interface that needs to be accounted for, which is this interface here that goes over quite a few centimeters. And then finally, in my experience, the relevant observation that is very typically not appreciated is the left hilum. The left hilum is not normally situated. The vascular left pulmonary artery, the hilum, is depressed and also rotated medially. If you look at the vessels going towards the hilum, these here, they're clearly going to a point which is more inferior and rotated medially than usual. So those are the main findings here of obstructive left lower lobe atelectasis, left lower lobe collapse. So obviously he's had some symptoms over time, but they were not severe. And he came in recently again with, I think, an unexplained cough. And really nothing has changed over time. So this is from 2024. The same findings are present. There's a bit more opacity here, but the findings are those of obstructive left lower lobe atelectasis. So here's a corresponding CT. Very nice findings of obstructive left lower lobe atelectasis. What is particularly notable is the presence of distension of bronchi in that lobe by intraluminal material, presumably mucus, secretions, what have you. And you can see how the major fissure is depressed. Oh, I forgot to mention that interface was the displaced major fissure between the atelectatic left lower lobe and the left upper lobe. And of course, in this situation, one looks for a central obstructing lesion, a little bit of areas going through, but not very much. And then here we can see that there is an endoluminal abnormality right here. Given the fact of left lower lobe collapse, one can reasonably intuit that this is the top of an obstructing lesion that is located here that protrudes into the distal left main bronchus. So it's a matter of making that diagnosis and also diagnosing the presence of the lesion. Now, this hasn't changed over a period of years, and it's a young person. So that points towards a benign endobronchial lesion. And this one turns out to be a pleomorphic adenoma. So here is see the case here, the total case. It's a salivary gland analog in the lung. If I remember correctly, pleomorphic adenoma is the most common benign lesion of the parotid gland. There are the findings, and here are some images. Typically identified in adults, can occur at any age, and apparently the findings are pretty typical for a pathologist. There's a ductal component with spindle myoepithelial cells in a chondromyxoid stroma, just like the salivary gland counterparts. And here is the overlying respiratory mucosa of the bronchus. So just a very brief review of salivary gland tumors. They may be malignant and may be benign. And among the benign lesions, the pleomorphic adenoma is a likely explanation right there. All right. Here is a really nice, interesting case. So I will show you. This is part of a pre-TAVI procedure. And I was looking at this one and something caught my attention. So I'm just going to scroll through here. This is obviously the non-contrast portion of an exam. And something caught my attention. I said, whoa. And I will bring up more images here. So while you folks are looking at it, I'll point out there are extensive calcifications, mural calcifications in the aorta. Patient has got aortic valve disease with calcified aortic valve cusps, so aortic stenosis. But what's really interesting are these calcifications, mural, related to the main pulmonary artery. And notice that they're really just located here and are not located more distally in the left or right pulmonary arteries and more distally going into the lungs. So I thought, whoa, that's really an interesting pattern of calcification. So I had to scratch around a bit, and I'll tell you that in a moment. But any thoughts from anyone about those calcifications? As you look at that, this is kind of almost like a porcelain aorta. There's so much calcification in the wall of it.
Well, going on a limb here, things I would think about for that ascending aorta is like old aortitis,
Okay.
from like autoimmune disease, so like a giant cell / Takayasu from many years ago, syphilis, of course. If there'd been radiation to the mediastinum, that's another possibility. So those are the big three I would think about initially. And then
Okay.
sometimes, because you can see it with atherosclerosis with longstanding pulmonary hypertension as well, but I don't think you've
But
shown
it's
any
curious
correlation.
in location, and these
Right. Yeah,
calcifications
it's
don't
kind of in that
exist.
shared sheath,
Yeah.
that shared
And
adventitial sheath.
right, with no other findings to suggest long-standing pulmonary arterial hypertension. But bingo, you got it right there, Jeff. Had to go back to the medical record, and this person was radiated for Hodgkin lymphoma in childhood, late childhood. So I think this is the first case I've seen of, well, this is sort of a form of accelerated atherosclerosis in the aorta as well. And of course, they may have accelerated atherosclerosis, but undoubtedly, yes, the explanation is this is a consequence of mantral radiation therapy for Hodgkin lymphoma at a young age. Very good. I think it's the first one I've seen
Does
like
the
that.
patient have a spleen?
Pardon? Spleen?
So, back in the day, they used to do splenectomy as part of staging, but that was a while back.
Oh, I didn't know that. There you are. Very good. So that was part of staging in the day,
Yeah.
right?
Is that a renal
Yeah.
cell cancer?
Look there. Oh, yes.
Right.
That might be a thing there too. Bilateral. I forgot to mention that.
Bilateral. Yeah, look at that.
Oh my goodness. Yeah, this person had a lot of surprises. Absolutely. I did not, yes, I did not think about or notice the absence of the spleen. Very good. Yes. Oh, look at that. Yeah, I remember that now. We did see that. That was a surprise too. So a bunch of surprises. I don't associate radiation therapy with bilateral renal cell tumors. That's just bad luck, isn't it? Hmm.
Yeah, maybe. Yeah.
Probably, presumably bilateral renal cell tumors.
Or some mutation that predisposes them to malignancies.
Yeah. Oh yes, good. Thanks. Thanks for the comment about the spleen. I didn't look there. All right, those are my two for this week.
All right, Howard. Thanks. All right, David or Travis. I see Travis is on.
Yeah, I'm happy to go if that's okay. I'm gonna have to get back
Yeah,
in the reading room.
of course. All you.
All right, let's see what we got here. So I'll start with this one since Howard just showed one. You should be able to see a radiograph.
Good.
Yeah.
And yeah, this is another one on the outside, not not detected prospectively in the community, but similar to what Howard was saying, hopefully this jumps out now as left lower lobe atelectasis. You can see there's volume loss in the left hemithorax. You get more of the flat waist sign with the straightening of the left mediastinal borders as the heart kind of rotates relative to the volume loss.
Mm-hmm.
What was picked up on this case though was just called kind of nodular infiltrates, which all of us kind of drives us crazy. But I think that helps to put together what's going on here. You can see there's this spiculated looking nodule here, and there's a very fine micronodular pattern throughout both lungs. And in combination with the left lower lobe atelectasis, then one certainly has to be worried about this all being cancer, which it did turn out to be, no surprise. And you can see on the lateral view the increased density as we follow down the spine, complete lack of a left hemidiaphragm here on the left side. And one of the things that's a little interesting here is the lesion isn't actually obstructing the left lower lobe bronchus, which I thought was kind of curious. It's more of just a tumor involving the basilar segments, as you can see here. So the bronchus itself is actually open, but the pleural fluid was positive. There's not really much discrete nodularity there, but they obviously have stage 4 disease and M1, at least M1A disease from the intrathoracic metastatic disease with nodules on both sides. So nice companion to Howard's case. And I think this, once you've seen it a few times, should just be instant pattern recognition here.
The interesting thing is that the worse the lower lobe collapse is, the lower the volume, the harder it is to see. It gets tucked right against the mediastinum. So, you might not see very much here, maybe a little paraspinal stripe on the frontal view. There's a little bit of mediastinal rotation here. And on the lateral view, the spine sign may be the only hint of it, because you don't actually see an edge very well. So the worse it is, the harder it is to see, which is ironic. So you think the left lower lobe was the primary site and the other nodules were metastatic, including that ragged looking one in the right mid lung?
Yeah, that's a good question. Just given the fact that it was most of the left lower lobe basilar segments that are replaced with tumor here, I think it probably was.
Yeah.
So, and I didn't pull up any of the follow-up CTs where things decreased. Your guess is as good as mine, but I would bet that it probably was. And who knows, could this be a synchronous primary? Sure. But I didn't delve into it that much. Just I thought this was a good radiograph.
Indeed.
All right, David, you're ready for this one, hopefully. This one, I'm now 0 for 1 in prospectively diagnosing this in my career. So as far and that's the ones I know of here. But so this guy is in his early 50s and had some generalized symptoms, and this included weight loss, some respiratory symptoms, some neurologic symptoms, and whatnot. And this is in 2022. He doesn't look that bad, October of 2022. And let's see, then November of 2022, interestingly enough, he's got some nodules that have popped up in both lower lobes. And you can see here, fairly discrete and solid. Some ground glass opacities in the right lower lobe as well. At some point during his whole trials here, he developed COVID. I don't know when that was, and it doesn't turn out to be relevant to the final diagnosis. So that was end of 2022. And then a few months later, this is really interesting because the discrete nodules have decreased. And now, I would argue it almost looks more like a perilobular appearance of organizing pneumonia with more of these just peribronchovascular and linear bands of consolidation with these arcades and areas of lobular sparing. So no discrete nodules, and no notable treatment in between there. That was March, and then this may be the same. That's the same time frame, just thicker images. And then here he came back, and this is actually, I reviewed this outside study with one of the pulmonologists, because this is when they asked me, they're like, what do you think? This is 5 months later, and now some of that background of linear bands of stuff is there, but now he's got these bigger nodules and some areas of consolidation, some areas of cavitation here. It's just really confined to the dependent lower lobes. He was not aspirating. And then there was a CT guided biopsy. There was a bronch at some point on the outside. Nothing grew anything. And now this is the most recent one, which is February, a couple months after he had a treatment for a related, or unknown at the time related, but now presumably related multi-systemic process. Any thoughts?
Multi-systemic process. Cavitations.
Yeah, it's kind of weird, right? It's just kind of these migratory things, just some organizing pneumonia, it looks like, in between there.
IgG4.
Does he have skin or brain lesions?
Yeah.
So he had bilateral optic neuritis. He had some other neurologic symptoms. And it was one of the tests in the CSF when they did between that and his optic findings that prompted a treatment.
That optic neuritis is a big deal, and I'm trying to remember what it goes with. It's not This isn't It's not a good distribution for sarcoid.
No, and that's one of the other things we tossed about. And of course, the cavitation would be weird for sarcoid.
Does he have asthma? I missed that if you said that.
No.
Because I was thinking about EGPA can do some weird neurologic things, but
yeah,
they all have asthma.
How about so somebody mentioned IgG4. I think that's not a bad idea.
I did, because it's everything that is weird looking.
It's funny. The diagnosis has also was mentioned in passing with one of the other cases, and I will show you his aorta and his pulmonary artery look reasonable, but this guy was given a dose of antibiotics for neurosyphilis, and all of this disappeared.
Oy.
Wow. Okay.
And so interesting. Usually it's Pen-G in the US. They actually gave him IV Rocephin, which is what they do in Europe. And so he had an excisional lymph node biopsy at one point. Like I said, he'd had this CT guided biopsy and bronch, which were all unrevealing. Never had an infectious workup that was positive. But I'll see. I think I got this. And this is kind of a busy note, but on his CSF, he had a positive RPR and something else, and then they treated him with IV Rocephin and completely better. So, and I think, David, have you shown cases of syphilis? Or I know we've seen at least one or two in the lungs, and like looking in the literature, it almost seems like it may be as much of a reactive response to a systemic process, and that's why I wonder if some of that organizing pneumonia looking stuff, is more of a secondary process. But I guess that's what this is.
I think I did.
It kind of looked like
I showed a
aspiration.
Gamma. Yeah. And I've shown a gamma in the lung, and I've shown some aortitis cases, some really old cases that were, with yellow angiograms and things like that.
Yeah.
Of syphilitic aortitis, but I think I showed one lung lesion. But this is remarkable. I would never have tumbled to this.
Is there something about
the aspiration from his just from having neuritis?
I mean, he was an outpatient, though. Yeah, I mean, that's what I thought, but it was kind of this first one. Yeah, I know. But it all resolved with the antibiotic treatment, and his symptoms, all of his symptoms are completely gone now after the dose of Rocephin.
So what were his risk factors for syphilis? I just wonder if he had other infections along the way too, if he had continuing risky behavior, and we've seen a variety of different infections in this one guy.
I mean, he went through a quite an extensive workup. Obviously, he was HIV negative, a bunch of other stuff negative. This is just one brief summary I quickly put together. But I've looked at a couple case reports, and there's you can find some that have similar looking stuff. Again, that's why I'm showing it as presumptive, but certainly not confirmed. And I don't think they're going to go back and pull the path. I may ask the pathologist, because the pulmonologist that just sent this to me, FYI, that things had gotten better with his antibiotics.
So it was the CSF that where they made the diagnosis?
Yep. So he definitely has neurosyphilis, and then this is just presumed secondary, lung involvement. I mean, yeah, Jeff, I agree. I mean, this doesn't really look, these are pretty discrete, solid, don't really look centrilobular aspiration.
No, those don't, but that last scan you showed looked much better distribution.
Sure.
And of course, it's going to get better because it's going to clear anyway. And if there's any infection, it may have been covered anyway.
Yeah. Yeah.
But yeah, the nodules don't fit with aspiration.
Yeah. All right, and then I saw this one, which I'm going to show yesterday's or this week's study first, and I'm going to kind of show it. So this patient, you'll see, if you kind of window it, when I first saw this and I was looking through it because it was a PE study, you think like, man, that almost looks like it could be exogenous lipoid pneumonia in some of these areas. But wait till I show you the lung windows, and you'll see that what that really is the only lung that has any reasonable parenchyma left. This is a patient in their 20s who has systemic lupus. And I've never seen this degree. I remember Brent showing, and I think they published some of those cases of lupus with kind of the four corners distribution when they do get involvement of the lungs. And there is a patulous esophagus. You wonder if there's some overlap with scleroderma or some sort of mixed connective tissue disease. But this has progressed, and I just thought this part of the lungs, this was just, she's symptomatic. I don't know if this is an acute exacerbation. I hope it's not a mucinous adenocarcinoma just involving what's left of her lung parenchyma, but I think some of the attenuation may just be from shunting of contrast as well. I just thought this was such an interesting appearance, though, that I had not quite seen before. It's almost like I was saying, it's like a pseudo exogenous lipoid pneumonia look to that lung parenchyma. What do you guys think?
I think it's diseased lung. I don't think it's preserved lung. I think it's diseased lung. It's either pneumonia or an adenocarcinoma.
Yeah. I mean, it's relatively, compared to everything else, it's the only thing that is reasonable. And actually, this is the intervening study. And so some of it is more acute, but I think, it's just more of the inflammatory portion of this process.
Mm-hmm.
Yeah.
So would you call this exuberant honeycombing? I think you could.
Yeah. Yeah, I mean, yes, you could. The thing that I still don't like about that is that, it's not UIP type of honeycombing because there's no traction here. You can even see the bronchi all the way out.
But the exuberant honeycombing is often not UIP-like.
Right.
And it's very thin-walled. And actually, we had a case where our pathologist said, I'm not really seeing fibrosis here. This is kind of emphysema. And I just wonder if she has LAM in addition to her lupus too. That would be another consideration.
I think, I think some of the areas being relatively spared argue against that, but
the earlier image that you showed us was very similar to the ones that were published in that paper, where you had these focal lesions that contain cystic spaces, just like that. Wow.
Yeah. So, all right, Jeff, I'm going to stop there because I'm going to unfortunately have to get back into the reading room.
Travis, can you hang on for me to show one case?
Yes.
Okay.
All right.
Better make it time. Okay. I wanted to show you this movie of a guy I did a diaphragm fluoro on, and I'll try to show you the. I would like actually to show you the diaphragm study first. Can you see a fluoroscopic image here that's moving?
Yes.
Okay. So this is this fellow who's middle-aged. He's a robust guy, middle-aged. He's very short of breath. He is unable to sleep flat. And this all follows an injury that he had in 2023, in June of 2023, where he had whiplash. He'd already had a cervical spine fusion at the point that he had this whiplash injury. So after the whiplash injury, he was very short of breath. He was unable to lie flat. He would sleep in a recliner, but pretty much propped up. And this is his diaphragm flora when he's standing up. Notice that his chest wall goes up and his diaphragm goes down. Looks quite good. Let me show you it on lateral. And you also see that he's got this nice anterior upward motion of the chest wall and a downward motion of the diaphragm on both sides. Looks pretty good. But then he sniffs, and watch what happens when he sniffs. Deep breaths. There's the sniff, and the diaphragm actually goes up on both sides. So his diaphragm leaps up on both sides when he sniffs, which is not normal. So the diaphragm and the chest wall should move away from each other. The chest wall is going to move up and forward, and the diaphragm is going to go down at the same time. But you see when he stresses things by sniffing, his diaphragm actually leaps up, not, it follows the chest wall passively. So that's bizarre. You should not be happening. It looks so good when he takes a nice deep breath, everything that moves normally. This is the same guy now when he lies down. Now he's supine at this point. And you'll see that as he takes in a breath, his diaphragm moves up with his chest wall. He doesn't breathe very much at all, but his motion is mostly from his chest wall, and his chest wall goes up and it pulls the diaphragm up with it. So here's chest wall going up and the diaphragm pops up with it. So his diaphragm is completely paralyzed on both sides, despite the fact that on standing, it looks quite normal. He takes a nice deep breath when he stands, diaphragm goes down, chest wall goes up. This is because he's using his abdominal muscles without being aware of it. He tightens his abdominal muscles, and that pushes the diaphragm up. When his abdominal muscles go in, it pushes the diaphragm up. When I ask him to take a deep breath, he relaxes his abdomen, and the diaphragm falls passively. It looks quite normal. So here's what the guy looks like. I tried to put him supine. He got desperately short of breath. And so this is the guy at 45 degrees. He was very stoic, and he was very nice to cooperate with this. So let me show you what happens when he takes in a deep breath. You'll hear the soundtrack here. Okay, take in a deep breath. Blow it out. So you saw when he took in a deep breath, his abdomen, your abdomen will go anteriorly when you take in a deep breath, because your abdominal muscles relax. As the diaphragm goes down, it pushes the abdomen down, and that bulges it anteriorly. But you'll see that his abdominal muscles here are actually moving paradoxically. They're going up, and the abdomen is going in as his chest wall goes up.
Yep.
Blow it out. So this is called paradoxical breathing, and this is a sign of bilateral diaphragm paralysis. Breathe normally.
Yep, thoracoabdominal paradox.
Yeah. Okay, so blow it out. Deep breath in. Blow it out. Deep breath in. Blow it out. Breathe normally. So this is a very dramatic example of how normal things can look on standing views. But if you stress the diaphragm by putting the person supine or by sniffing, you can see this paradoxical motion. So, you know, sniffing is one stress test, and supine position is a potent stress test too, and it really brings out these cases of bilateral diaphragm paralysis that you might miss if you just had standing views. So I was really happy to be able to get this nice video of abdominal paradoxical motion here. Okay,
Yeah.
now the guy then had surgery about 3 weeks ago or 2 weeks ago. They went in and did a laminectomy, extensive cervical laminectomy. They put in spinal rods and pedicle screws. The guy woke up from surgery and says, "My diaphragm is cured." It's fairly rare that people with central central cervical spine trauma benefit from decompressive laminectomy, but he did dramatically. So because it's rare, but because he was so disabled, they went ahead and did the surgery, not expecting much, and instead they got a spectacularly good result. So the guy's due back in the clinic tomorrow, and so I'm going to do a sniff test on him again tomorrow, and we'll see how much better he is. But I thought this was a dramatic example. It's the one time I have a video to show you abdominal paradoxical motion. So once again, if bilateral paralysis is an issue, you have to include supine views on your sniff test. Okay, Travis, you can go be a clinical doctor, save lives. Thank you.
That's a very good case.
That's cool, David. Thanks. All right, is that it for you?
That's it for me.
Awesome. All right, I have a few I can show here. Let's see. Let's see. There we go. All right, we'll start with this case. So this is a young patient that presented with cervical lymphadenopathy, and you can see on this chest CT. You're not seeing my screen?
No.
Yes. I see
How
it.
about now? Do you see it? A CT?
I do.
Now we do.
Yeah, there. Okay. Anyway, you can see there's an enlarged supraclavicular node here, and so they were worried about other things. There's a kind of juicy axillary node here, but you look in the anterior chest wall, you see there's this stranding and skin thickening here, and there's this what looks like an abscess with a lot of edema around it and soft tissue thickening. And those are the only findings. The lungs, there's nothing going on in the lungs. So they actually biopsied one of the lymph nodes, and it showed necrotizing granulomatous inflammation, and they grew grew tuberculosis from it. So this is a case of a tuberculous abscess. I don't even know if there's a name for it. A tuberculous abscess in the skin or under the skin here. There's probably some names at some point somebody gave it, but anyway, presenting. Usually we think of lymphadenitis presenting in young kids. But there's no pulmonary tuberculosis, which I can't figure out. But I've seen lesions and all that, and joints, but not something like this. I mean, I was figured this would have been staph or something, but a case of TB.
But Jeff, no history of skin injury, and it's definitely TB and not some atypical, right?
No, it's TB. It's MTB.
I thought you were going to tell me it was blasto.
No, it's TB. And
wow.
Along those lines, here's another patient who presented with hemoptysis, was treated for TB many years ago. And you can see the left lung is pretty much just mostly destroyed. And interesting let me show this image instead. On the right lung, you can see there's mosaic attenuation, there's bronchiectasis, there's probably some air trapping. So there's a lot of small airway injury as well. And you can see the left lung is completely trashed. Which is interesting because it's not something I think about with TB, but if we come back and look at this side here, I think the cause for the hemoptysis is a little bit more obvious. There's one of the larger ones I've ever seen, but a huge aspergilloma sitting in this cavity. So this patient had a bad case of TB, but I don't know. I don't know if I buy all this old stuff on the right being just from old TB. I guess it's possible they do get bronchiolitis, but this is more like ignoring the left lung, like what you see in a so-called Swire-James, where you get, some scarring, some bronchiectasis, and a lot of distal air trapping.
Yeah, I agree. That looks more.
No active TB at this point. It was treated many, many moons ago.
I think this person's had more than one infection.
Yeah, that's what I kind of suspected. But it's kind of neat because, most of the time when I see cavities, it's from sarcoid or, bullae that get infected with these aspergillomas. But in this case, truly old TB, which is still probably the most common cause in the world. But this to me is just, I don't know. We don't see a ton of TB, so it's hard to know what that was from. Let's see. This is an 80-year-old, and this was just something. It's funny. I found out apparently my residents it shows up in all the review books. This is something we talk about in airways disease, but if this patient had COPD, you can see the saber sheath trachea, but look at these submucosal or mural nodules here in the trachea. You can see it's got a little cartilaginous cap. As we go down, you see there's a whole bunch of them, not doing much really to the lumen, but definitely a real finding. So this is something I see never to this extent of tracheobronchopathia osteochondroplastica, which is really just a hypertrophic response, probably to chronic irritation. And usually see these small, smooth bumps. Ignore them, usually in patients who've smoked. But this is one of the few. Arlene showed one. Oh, sorry, I get the windows right here. Years and years ago, when we first started this conference, a pretty exuberant TBO, and I think this is probably a second place to it. But apparently it's something they are studying for their boards and show up on various situations. But I don't know. It's so rare. I mean, considering all the CTs we look at all the time, I've never seen it this exuberant myself. So a nice example of.
To the main bronchi too, Jeff?
Not really. Which is but keeps with what I've seen when I see the small bumps. You'll notice it doesn't involve the posterior membrane at all, which is typical of it.
So the bronchoscopists have told me that sometimes they'll see mucosal irritation over those bumps. Mm-hmm. So I think they probably snag some secretions or something like that and can get inflamed.
Yeah. And usually they're not calcified. Usually they're just little smooth bumps. Like if you look on CTs, though, if you scroll through them and look at the airways, you'll see these broad-based, flat little bumps right on the rings. And I remember early on, I did some virtual bronchoscopies just to prove that they were actually on the rings. And then you can see the membranous insertion is right here, and that's why it kind of flares out like that. But this was kind of just a cute case. This is a fun case. One of my senior residents made a great call in this case. So this was just follow-up for metastatic renal cell cancer, and we see a lot of these. And it's got a couple fun findings. First, it's got a right aortic arch with the flavor of mirror image branching. It's not a double arch with an atretic segment. No congenital heart disease, no history of congenital heart disease. Descends on the right, does all the things it's supposed to do. It's head-old histoplasmosis, usual stuff. But my astute resident noticed these holes in the lung, and the buzzword, of course, is floppy cysts. Right? These aren't nice round cysts like we see with other things. You notice them; they're elongated. They're often on the pleural surfaces, and the more you look, the more you'll see them. Clearly have a basal predominance. And so we signed this out, and with the history, and it was a clear cell renal cell. There's one there. Sometimes you see them, like, I don't know if they're where they are in the lung, if it's right on the fissure, or if it's, I suspect it's actually subpleural and along the fissure. Yeah. But if they've had a pneumothorax in the past, I guess it could get loculated. I mean, like this tiny one even here. So we signed this out as Birt-Hogg-Dube. I mean, it all of it fit. And the oncologist confirmed the guy does have skin lesions. He's had many of them removed. Has several family members who had kidney cancer. And has another relative with skin lesions that's showing some of the skin lesions. So they're going to do genetic testing. It hasn't been confirmed yet, but this is Birt-Hogg-Dube syndrome, but it's important. And the previous imaging had been done elsewhere, and it had not been commented upon. And I think it's important because of screening of family members, because they're at risk of renal cell cancers. So I think they're still recommending annual ultrasound in asymptomatic patients. So have a low threshold.
Jeff, I think clear cell carcinoma is at an increased risk. They're not always the more benign kidney tumors. They have an increased risk of clear cell renal cancers, the ordinary kind as well. Is that correct?
Yeah, they're at increased risk of renal tumors, but apparently clear cell is the more common one that you see with Birt-Hogg-Dube. But they can also get oncocytomas and other weird ones. I don't know. When I was in training, in school, we just talked about renal cell cancers. We didn't really split the difference that much, but these are the characteristic. And I can't remember where the term floppy cyst came from. I've always liked it. I think I read an article years ago that described them. But I always like these stretched out cysts. They don't look like the cysts you see in Sjogren's disease or amyloid, where they're round, even though they're lower lobe and they often have vessels, they're rounder. And then, of course, the distribution doesn't fit for other things, but they're still very simple looking cysts. And another way, let's see if I can find one. sometimes you'll see them at the septal-pleural junction. So they'll run perpendicular to the pleural surface. And I don't think he had a good one. But they look like they're at where the septum, the interlobular septum, inserts into the pleural space. I don't see a good one on this page. Right here. You can see there's the vein, so you can see it's running right along that septum, and see how the orientation is perpendicular to the fissure. And that I found is a very helpful appearance. And then they like to hang out near the big pulmonary veins, usually in this medial. So, and they seem to, I don't know, I mean, I've seen several of these patients present with pneumothoraces, and with any cysts, of course, we see them, but I see it at a much higher frequency than other diseases. And I think it's because these cysts are right at the pleural surface. So if one of them ruptures, it's much more likely to take out the pleural space than someone with central cysts from Lamb or somewhere else, where even LCH, where they tend not to be so close to the pleura. So this is kind of a neat, good case here where we made a big difference. Now, this last case is a curiosity that I wish Travis were here to comment on, but you guys might have some insight. So this was, I can't remember what I was doing this for, and I just, I get these windows wrong every time. There we go. But what caught my attention was this right here. I was like, what is that? And then I realized that's a stent. So you can see the left coronary, there's a stent in the left main coronary, but it's clearly not coming off the left cusp. It's coming off the right coronary. So this is an interarterial course of a left main coronary, which we've, is associated with sudden cardiac death. And this is an older patient. And as far as I know, there's no defibrillator or anything. There's no history of sudden cardiac arrest. But, they usually surgically repair these. And I've never seen one stented before. And I wonder if they opted to do that because maybe the patient wasn't a surgical candidate. It kind of looks like he's had an old, at least a non-subendocardial infarct there. But he's got a lot of coronary disease. But have you guys ever